Yep.
Okay, super. Okay,
okay.
fire away, Magnus.
Thank you. And I will just ask you to change slides when necessary. Thank you for waiting. I'm going to tell you a little bit about my PhD thesis, which is done under the supervision of Paul Salkovskis and Fridrik Sigurdsson. And I labeled my lecture One Small Step at a Time, Search for Transdiagnostic Mechanism Change. And change slide. The mechanism that we are checking out and have been thinking about for the past several years, me and Paul and Jon and more, is a hypothesis that Paul put out in '96. He called it Theory A, Theory B. And he described it as working with the patient to develop an alternative, less negative explanation for the problems may be a key mechanism of change in CBT. He labeled this as a cognitive flexibility, but at the simplest, it has been described as an involving shift from beliefs from Theory A to Theory B. And here you can see Theory A and Theory B of a recent patient that I was treating. And according to Paul, what he measures is the believability in Theory A versus Theory B. So when treatment is going well, Theory A should be going down and Theory B should be going up. Change slides. I'm going to talk about two studies in my thesis. Study one, which was a thematic framework analysis. We included 24 patients from a former trial, which was published in 2018. We split the groups into halves. 12 received an effective treatment, the other 12 non-effective, and we interviewed them about the treatment and what was helpful. And the research question there was, are themes different in the effective group versus the non-effective? Study two, that was a single case experiment design or non-concurrent multiple baseline with 10 patients. We developed a 10-session novel transdiagnostic treatment, and the research questions there were, is the 10-session treatment efficacious in the treatment of various mental health problems? And is it possible to establish the timeline of changing in the treatment? Change slides. And as you can see, we found 4 overarching themes: cognitive and behavioral flexibility, awareness and understanding of symptoms and triggers, therapeutic alliance and engagement, and attitudes. And change slides. This was the first themes that was different between the groups. The people in the effective group were much more direct in using their cognitive intervention, therefore more cognitive flexibility. Change slide again. The non-effective group had more negative attitudes towards the treatment, so they were not going into the treatment. They found the treatment boring and so forth. Change slide. And majority of the effective group participants found the therapist good, helpful, caring, and so forth. Change slide. You can see here in the direct quotes, and change slide, Warren, please. Here is the first direct quotes. This instructor was very nice. He was caring and so forth. Change slide. Here you can see direct quotes from the negative attitude. Change slide. These are direct quotes from where the people from the effective group, how they describe their cognitive flexibility. And change slide. And here you can see a direct comparison between a direct cognitive flexibility versus thinking about things in a very diffuse way or in concrete way. For example, think differently. I just know somehow that you think completely different. Therefore, change slide. We thought, how can these results be applied? We therefore developed a 10-session novel transdiagnostic treatment. And as you can see from session 1 to 4, we were facilitating and enhancing cognitive flexibility. Session 5 to 8, we were testing it out in behavioral experiments, and then relapse prevention. Change slide, please. Thank you. I would like to put your attention to 2 things. First, on the right-hand side, you can see our participants, Theory A and Theory B, and you can see on the left-hand side the results. And if you look at the dark squares, these are symptoms. Triangles are Theory A, and rings are Theory B. Change slide, please. As you can see, if you look at visually, the diminished believability in Theory A followed the diminished symptomology much closer than the reverse trend in theory B. Change slide. Same story with panic. Change slide, please. Yet again with major depressive. So change slide, please. So as you can, if we could draw together shortly, we found that in study 1, cognitive flexibility was highly important, but how patient used intervention was more important. They also had negative comments. These results affected how we developed study 2. So in study 2, we found that variability was higher than we expected, as you saw briefly on these slides before. The trend of the mental health symptoms seems to follow the trend of theory A more than the reverse trend of theory B, which puts our attention to which model might explain these results, the activation model versus accommodation model. And we also found that stimuli evaluated as threatening seems to be a moderator. So it was much more difficult to treat people with OCD suffering from mental rituals versus observable behavior. Change slide, please. So where are we going from here? We would like to evaluate possible moderators. So for example, lack of causal explanations, perseverance of thought, severity of mental health problems, and especially how we can make people choose to change. And Warren told me to round up, so I have finished. Change slide, please. Thanks for inviting me, and thank you all for listening, and be patient when I was having trouble with my technical abilities. Thank you.
Thank you, Magnus. Let's have a clap for Magnus. Thank you. Well, these are called rapid talks for a reason. Mm-hmm. So thank you, Magnus. Next, we have Bryanna Mackey, who's going to talk to us about effortful control. And Bryanna's from Skidmore College in USA. I'm just going to make you co-host so that you should be able to share your slides with us. Awesome. Sarah, if you could manage the recording, that'd be great.
Yes. Will it just prompt me with a button to hit recording?
Sorry, Sarah's going to manage the recording.
Oh, sure.
But if you'd like to
still recording, so I'm just keeping.
Oh, just see it through. Yeah. So if you'd like to share your screen with us, Bryanna.
Yes. No problem at all. Let me just get to the tab. Oops, sorry, getting ahead of myself. All right. Hi. So I'm Bryanna Mackey. I'm a recent graduate from Skidmore College. Oh, am I being heard okay? Just wanted to check. Okay. Yes, I'm a recent graduate from Skidmore College, and I'm presenting to you today on a study I was looking at that was looking at effortful control as a transdiagnostic predictor of the development of new disorders after previous remission. I created this project with my mentor, Dr. LaFreniere. Unfortunately, he can't be here today, but I could not have done this without his great mentorship. Alrighty. So given comorbidity and clinical complexity, it is vital to identify predictors of beneficial outcomes across different disorders, and to kind of address the problem of barriers to treatment and barriers in accessing treatment. It's very important to look at transdiagnostic mechanisms to hopefully potentially in the future create more therapies that can address transdiagnostic factors to help treat any disorder anyone presents with to any therapist. And so while many factors have been shown to predict remission in single disorders, there are fewer predictors of broadly transdiagnostic change. So by broadly transdiagnostic, I specifically mean encompassing the anxiety, mood, obsessive, traumatic, psychotic, attention deficit related disorders. So really encompassing the internalizing and externalizing disorders. And so effortful control is one possible broadly transdiagnostic factor, and I'll get into that, why that might be. So basically, effortful control is the ability to shift attention productively and resist both unhelpful avoidance and approach motivations. So those are common processes in psychopathology. Specifically, it's hypothesized that avoidance is really pertinent to the maintenance of internalizing disorders and unhelpful approach. So not being able to resist your inherent temptations or urges, that is really prevalent to the externalizing disorders. And so EC is this construct that is encompassing across both of those categories. And so EC has shown transdiagnostic influence in research on the reduction and remission of various disorders examined separately. So in just among single samples of anxiety, mood, and other disorders, as well as in a transdiagnostic singular outcome. So encompassing across all of those disorders, like in P-factor studies. And so, as I mentioned, EC has been implicated in this broad assessment of transdiagnostic disorders. And this suggests its potential as a broadly transdiagnostic factor. Another concern that we want to address in this study is only looking at remission. And so in the data we used, we found that in patients who had previously remitted from a disorder, they would often be diagnosed with the SCID with a different disorder afterwards, despite that remission. And so remission, so we call this diagnostic exchange, the phenomenon in which one disorder would remit and be replaced with another one at a later time point. And so this really speaks to the fact that remission is one stone on the path to comprehensive mental health treatment assessment. And remission is far less desirable if someone relapses or experiences remission only to develop another disorder in place of the previous one. And so this measure of diagnostic exchange captures a more comprehensive picture because it's looking at not only did you remit from one disorder, but were you able to not develop a new disorder in its place. And so the current study utilized data from the Nathan Klein Institute Rockland sample. It assessed a variety of clinical targets in a non-treatment community sample. So we looked at 87 participants, age ranging from 16 to 71, and participants received 2 diagnostic interviews with the SCID, administered an average of 1.5 years apart. And to be included in our sample, participants had to receive a DSM-5 diagnosis at least one time point. And we utilized a broadly transdiagnostic sample, as I mentioned before. And so we specifically looked at factors involving questionnaires such as the Adult Temperament Questionnaire, the Penn State Worry Questionnaire, the Emotion Regulation Questionnaire, and the Ruminative Response Scale. And we assessed diagnostic exchange, that phenomenon, as a participant's second time point, showing both remission of a disorder listed at their first time point, as well as the presence of a new unrelated diagnosis in its place at that second time point. And so to predict the amount of disorders that were replaced at the second time point, we use an ordinal logistic regression model where EC, positive affect, negative affect, worry, sorry, I can't see my slide.
This is great, Bryanna. Can you round up with your main findings, please?
Yes, predicted diagnostic exchange. And so when we did that with our ordinal logistic regression, we found that effortful control was the only significant result, showing that low effortful control was related with higher likelihood of developing a higher number of new disorders in place of a previously remitted disorder, as you can see here. And
can you round off with your conclusions now, Bryanna? Thank you.
This basically suggests that the ability to resist harmful behavioral avoidance of discomfort and unproductive approach-oriented coping mechanisms promotes transdiagnostic remission and prevents the development of new disorders. However, this was a non-clinical sample, it was a convenient sample, and we were not able, there was no measure of therapies being utilized by this sample. So we were unable to see if this was a possible confound.
Thank you very much, Bryanna. That's super. A lot of information, short time.
Sorry about that.
Super.
Thank you so much.
No worries, thank you. I'm going to pass this on now to Rachel Goldblum, who's from Hartford Hospital, USA. It'd be great if you could share your screen. I think you're already co-host. Super.
Okay, so I did a more traditional poster, but so my presentation will be talking about transdiagnostic factors for cannabis use in an analog high worry sample. So generalized anxiety disorder, which is characterized by chronic worry, has been linked to increased risk of substance use during, including cannabis use specifically. However, unfortunately, the co-occurrence of GAD and substance use remains relatively understudied. So we know that using substances to cope with negative emotions is associated with more problematic substance use. And given this, understanding factors that not only contribute to cannabis use, but also drive coping motives for use is particularly important. So intolerance of uncertainty, which is difficulty withstanding distress elicited by uncertainty, and anxiety sensitivity, fear of anxiety-related symptoms due to perceived negative physical, social, or psychological consequences. And while some research indicates that both AS and IU are relevant to substance use, including coping-oriented substance use specifically, no research to date has examined their relative contributions to cannabis use or coping motives for cannabis use among individuals with GAD. So theoretically, IU and AS may motivate individuals with GAD to engage in cannabis use as a form of coping with distress elicited by uncertainty or anxiety-related body sensations, thereby increasing cannabis use over time and worsening GAD symptoms. So examining these relationships may advance theoretical models and intervention efforts. The aim of the current study was to evaluate the relative contributions of IU and AS in terms of cannabis use and coping motives for cannabis use among college students with clinically elevated levels of worry. It was hypothesized that after controlling for the effects of gender-negative affect, both IU and AS would uniquely predict cannabis use and coping motives for cannabis use. We also conducted exploratory follow-up analyses examining IU and AS subscales as unique predictors of cannabis use and coping motives for cannabis use. The participants were 91 college students with clinically elevated levels of worry who reported a history of cannabis use and completed online measures for course credit. They were primarily white females, and they filled out the intolerance of uncertainty scale, the anxiety sensitivity index, a question on past 30-day cannabis use, the comprehensive marijuana motives questionnaire, and the positive affect, negative affect schedule, but only the negative affect subscale was used. So we put the tables on the next slide just because of lack of room on the poster, but if we have time after, if anyone wants to see the tables specifically, I can show those. But we used a series of hierarchical linear regressions to examine the relative contributions of AS and IU on past month cannabis use and coping motives for cannabis use. AS and IU were entered simultaneously at step 2 for each regression model. So we'll first look at our cannabis use outcome. Step 2 was significant and accounted for an additional 21% of variance. Greater AS was significantly associated with greater past month cannabis use and accounted for 11% of unique variance. IU approached significance and accounted for an additional 3% of variance. In terms of AS subscales, greater physical concerns was significant and accounted for 5% of variance, and cognitive concerns approached significance and accounted for 4% of unique variance. For IU subscales, we see that only the inhibitory subscale was associated with greater cannabis use and accounted for 5% of unique variance. So now we'll examine the coping motives outcome. IU and AS were entered simultaneously at step 2 and approached significance, accounting for 10% of variance. Neither AS nor IU significantly predicted coping motives for cannabis use. However, AS approached significance and accounted for 7% of unique variance. We examined the predictive utility of AS subscales. Only AS cognitive concerns emerged as a significant predictor of greater coping motives for cannabis use. We also examined the predictive utility of IU subscales, and there was a trend level effect for inhibitory IU. So the results suggested that the fear of anxiety-related symptoms, particularly due to perceived physical consequences and behavioral inhibition in response to uncertainty, may play a role in increasing cannabis use in young adults with clinically elevated worry. Coping motives for cannabis use appear to be driven by feared cognitive consequences of anxiety-related symptoms, which makes sense given that GAD symptoms are largely cognitive in nature. Pending further research, it is possible that AS and IU may be important treatment targets to reduce cannabis use among individuals with elevated levels of worry or even GAD. However, future research is needed to replicate these findings longitudinally and in a more diverse clinical sample of individuals with GAD.
Thank you, Rachel. That's super. Really nice overview there to be able to see it all together. So well done.
Thank you.
Okay. I'd like to pass this on next to Celine Fox, who's talking about metacognitive confidence from Trinity College, Dublin in Ireland. Celine, over to you. You can share screen.
Hi, everyone. Can you see my slides?
Yeah, you just need to put them on display.
Perfect. Great.
At 15:37.
Okay, so hi everyone, my name is Celine. I'm a PhD candidate at Trinity College Dublin, and today I'm going to be talking to you all about how metacognitive biases and anxious depression improve with therapeutic gains, evidence from a 4-week observational study of internet-based cognitive behavioral therapy and antidepressant treatment. So as an overview of what I'll be talking about today, I'll firstly introduce the topic of metacognition, evidence for metacognitive associates with psychopathology, and how to utilize a transdiagnostic approach to metacognitive dysfunction. I'll then lead into the precision in psychiatry study, and I'll just run through the aims of that study, our methods, results, and some preliminary conclusions. So what is metacognition? Well, metacognition refers to our ability to monitor and appraise our cognitive experiences relating to our perceptual experiences, memory processes, and also decision making. And a prototypical example of meta-perception is something called perceptual confidence. So an everyday example of this would be if you're walking down a really busy street and you see a woman walking towards you. You may think at a distance, oh, that's my friend Jane, but you're not really sure because she has her mask on and she's quite far away. And as she comes closer to you and you have more access to the perceptual information in your environment, your confidence increases that this is actually your friend Jane, and you make a decision then to wave at her and call out her name. So really these confidence judgments inform our decision making and our behaviors. So when these confidence judgments go awry, this can lead to aberrant decision making and pathological behaviors. So when we want to measure metacognition, there's loads of different ways that we can do so. But one of the most common tasks that we use to measure metaperception are perceptual decision-making tasks and visual analog scales to assess confidence. So as an example of this, you'll be shown 2 boxes with varying number of dots, and you're asked to make a choice as to which box contains more dots. So looking at this, I would say, oh, box B contains more dots. And then afterwards, you're asked to rate your confidence in that judgment. So you'll be showed a visual analog scale, and yeah, I'm pretty certain that box B has more dots. So I would say I'm certain here. And if you do this repeatedly over time, there's different facets of metacognition we can derive from your responses. So 2 facets that were particularly relate to metacognitive bias and metacognitive sensitivity. And bias refers to your mean levels of confidence, regardless of whether you're correct or incorrect. So for example, here, someone with low bias would have a low confidence score along the y-axis, while someone with high bias would have an elevated confidence rating on the y-axis of how they rate their confidence. In addition to this, we're also interested in something called sensitivity, and this is the extent to which your confidence ratings discriminate between correct and incorrect trials. So when we measure sensitivity, someone who has low levels of sensitivity, their confidence ratings on correct and incorrect trials don't really discriminate between those kinds of trials. But when they have higher sensitivity, or their confidence is low when they're incorrect and high when they're correct. And the sensitivity measure can be biased by objective performance. So when we ratio this against accuracy, we get this measure of metacognitive efficiency. So there's been loads of research looking at how people with different mental health disorders perform on these metacognitive tasks. And there's evidence showing abnormalities in confidence across a wide range of mental health disorders. So for example, people with depression and anxiety tend to have low levels of confidence, and people who have delusional type psychosis can have elevated confidence despite underperformance on tasks. But when we actually synthesize this research and look at it in its totality, these findings of metacognitive impairment across psychiatric disorders actually tend to be quite ambiguous, inconsistent, and non-specific. So for example, we see the same kinds of abnormalities across disorder. And these results, there's lots of potential reasons as to why this might be, but one reason may be due to the way in which we actually define mental illness. So under the traditional psychiatric nosology, we define these categories. So we healthy and depressive, and and it's estimated that 50%.
Celine, do you want to check your connection? Oh, I think we've just lost Celine there. Which is unfortunate. Sarah, are you there?
I am, yes. I've still got the recording going. I'm just going to pause it.
I think you might have to. You might have to backtrack a couple of minutes, Celine, when you do that, and if you can possibly check your network.
Yeah, so sorry, when did I lose connection there?
About 3 minutes ago.
Oh, no, really? Okay.
Just at the beginning of this slide.
Just at the beginning of this slide?
Yeah.
Okay, perfect. Sorry about that. Yeah, the internet here on campus has been pretty spotty today. Basically, the point I was trying to make is that the way in which we define mental illness doesn't reflect clinical reality, because we see heterogeneity within psychiatric disorders and homogeneity across disorders. So we need alternative ways of defining mental illness. So one approach that we can take is something called the Transdiagnostic Approach to mental illness. So under this approach, what we can do is cut across those traditional transdiagnostic boundaries and actually reduce data into factor scores. So for example, we can measure lots of different items relating to psychopathology and then reduce using, and this is done previously through by research by Professor Claire Gillen, showing that actually when you reduce items relating to transdiagnostic dimensions and psychopathologies like alcoholism, apathy, depression, eating disorders, anxiety, impulsivity, OCD, schizotypy, and social anxiety, you can represent these items through 3 factors relating to anxious depression, also being and social. And it's also been shown previously that actually when you look at metacognitive dysfunction and its associations with these transdiagnostic dimensions, these dimensions explain variability in psychopathology more so than these traditional categorical approaches. Sorry, can you hear me there?
Yes, we can hear you.
Okay, fine, thank you. Sorry. Yeah, just the screen just froze there. So yeah, it's been shown previously that when people complete a perceptual decision-making task, On Amazon Mechanical Turk, people with high levels of anxious depression tend to have reduced confidence, and people with high levels of compulsive behavior and intrusive thought tend to have elevated levels of confidence. So this has been shown previously in the general population cross-sectionally, but it hasn't been replicated in clinical samples. So what we were interested in doing with the Precision in Psychiatry study was investigating if we could replicate the association between metacognitive dysfunction and transdiagnostic dimensions in a clinical treatment-seeking sample. We also wanted to see if metacognition and its clinical correlates improve following treatment, and also if metacognitive biases in anxious depression are state-dependent or trait-like. And by that I mean is if we see improvements in anxious depression and compulsive behavior and intrusive thought, do we see changes in metacognition, or is metacognition relatively stable regardless of fluctuations in psychopathology? So in terms of our methods and design, so we recruited people who were starting either internet-based cognitive behavioral therapy or antidepressant treatments. And so far, we've recruited 615 people who are starting treatment for internet-based cognitive behavioral therapy with a mean age of 31 and 77% of female. And we've also recruited 102 people with a mean age of 29 who are 72% female within our antidepressant arm. And we excluded people who weren't 18 to 70 years old, who weren't starting their treatment within the next or last 2 days of screening, and also people who scored less than 10 on the Working Social Adjustment Scale as an assessment of impaired functioning. So what we did was at baseline and 4-week follow-up, we got all of our participants to complete a battery of self-report questionnaires that measured alcohol addiction, apathy, depression, eating disordered symptomatology, impulsivity, OCD, trait anxiety, schizotypy, and social anxiety. And we used these scales to derive scores relating to 3 transdiagnostic dimensions, which I mentioned earlier, relating to anxious depression, compulsive behavior, intrusive thought, and social withdrawal. And we also measured depression using the quiz and impaired functioning using the Working Social Adjustment Scale. We also asked our participants to complete a metacognitive task in which they were shown 2 sunflowers with varying numbers of seeds. They were then asked to make a choice as to which sunflower contained more seeds and rated their confidence in that choice. And they did this over 210 trials, and from that we derived their mean confidence and their metacognitive efficiency values. So in terms of our findings, the first things we noticed was that we see significant improvements in our scale scores from baseline to follow-up. So after 4 weeks of iCBT and antidepressant treatment, we see significant improvements in anxious depression, but within our antidepressant arm here and our iCBT arm here. So our antidepressant arm here had an improvement in anxious depression with an effect size of around 0.75. And our antidepressant and our iCBT arm had improvements in depression with an effect size of impulsive behavior and also various scores, except for impulsive eating disordered scales and schizotypy scores. So again, this really speaks to the transdiagnostic nature of these treatments, internet-based cognitive behavioral therapy and antidepressant treatments, that you see not only improvements in anxious depression, but also improvements in symptoms relating to obsessive compulsive disorder, apathy, social anxiety, and also just general functioning. So then beyond this, we looked at the baseline association between metacognition and psychiatric dimensions, and we found that controlling for gender effects, individuals with high levels of anxious depression tend to have lower levels of confidence, and people with high levels of compulsive behavior and intrusive thought tend to have elevated levels of confidence. And metacognitive efficiency was not associated with any of our dimensions. And this is consistent with what was previously reported in that large sample from the general population. And then what's notable as well is that individual scale scores were not associated with metacognition. So really variance in metacognitive abilities is explained better by transdiagnostic dimensions than traditional categorical scale scores. We also seen significant improvements in mean confidence from baseline to follow-up in our iCBT arm. And we also saw significant improvements in metacognitive efficiency from baseline to follow-up in our iCBT arm. And what's interesting is that we actually saw this association between changes in metacognition and changes in anxious depression, in that people who had the greatest changes or improvements in anxious depression had the greatest increases in confidence at 4-week follow-up. And we didn't see this association with metacognitive efficiency, indicating that this effect is specific to metacognitive bias or mean confidence. And then we also looked at these results in our antidepressant arm, which had a relatively smaller sample of 78 participants of follow-up. And again, we didn't see this association between baseline between metacognitive biases and anxious depression and compulsive behavior and intrusive thought. But we know from previous research that this sample was underpowered to detect that effect. We saw significant improvements in mean confidence from baseline to follow-up, but we did not see improvements in metacognitive efficiency. And again, we didn't see that association between changes in anxious depression and change in mean confidence or metacognitive efficiency. But again, just to highlight, this sample size is relatively smaller than our iCBT arm, which had data on 459 people of follow-up. So again, our OR values and beta values are similar. Our P values are just not significant. So it'll be interesting to see if these associations are also significant when we have a larger sample within this group. And then finally, just as exploratory analyses, we also found that within our iCBT arm, changes in trait anxiety, depression, OCD, and compulsive behavior and intrusive thought were also associated with changes in confidence. Individuals who had the greatest improvements on these scores also had the greatest improvements in confidence. And within our antidepressant arm, we saw people who had the greatest improvements in apathy had the greatest increases in confidence. But again, these analyses were exploratory and p-values were not corrected for. So just to sum up, we found in this large sample of 2 clinical cohorts undergoing iCBT and antidepressant treatment that individuals with higher levels of anxious depression tended to have lower levels of confidence, and people with high levels of compulsive behavior and intrusive thought tended to have elevated levels of confidence. And we found that this metacognitive confidence improved following 4 weeks of iCBT and antidepressant treatment. We also found that this increase in confidence scaled with the reduction in anxious depression following iCBT. And that this suggests really that these metacognitive biases in anxious depression are state dependent and can be targeted through treatment. And then finally, just to note in terms of future directions, we also have data on, so we, just to note for future directions, we noticed individuals who had high levels also had confidence, while we would expect that those people would actually have a reduction to normalize their overconfidence. So we're looking to see if we can replicate these effects among individuals who are starting treatment for binge eating disorder. We're also going to consider whether or not our sample were undergoing concurrent treatment. We have data on treatment cessation as well during the study. We also have data on the types of iCBT and antidepressants people were starting. We also have data on treatment engagement and dosage. We've also looked at whether or not people were careless or inattentive responders, as we collected all our data online remotely. And then we also want to see if these changes in confidence are a time effect by looking at how metacognition changes among healthy controls from baseline to 4-week follow-up, which we're currently recruiting for. And then other confounds we want to consider for confidence ratings are things like intelligence and decision-making processes. So thank you for listening. I'm so sorry about all the technical difficulties, but I just want to thank my co-authors and especially Professor Claire Gillen, who is my current supervisor, and the funding board. So this project is funded by MQ and my PhD is funded by the Irish Research Council. And thank you again so much for listening, and apologies again.
No worries, thank you. Well done, Celine. Managing the technical issues, but such a comprehensive design and very neat slides there, well presented. So thank you very much. Our final speaker before the break is a colleague of ours, Colette Hirsch from King's College London, who will be talking about recurrent negative thinking. And I can see you're starting up already, Colette, so fire away.
Thank you very much, Warren and Sarah, for organising the conference. It's brilliant. Really enjoying it. So now, for some reason, so my slides won't go forward. Oh yes, they have now. Okay. Okay, I think that's the next, yeah. Okay, so everyone probably knows that repetitive negative thinking is a transdiagnostic process evident across, the general population, but also is evident in most psychological problems. So from psychosis through to anxiety, depression. You'll find lots of worry and rumination, and worry and rumination both co-occur within, for example, anxiety problems. People will ruminate and vice versa. So it's really a transdiagnostic process. And repetitive negative thinking, or RNT, really does predict and maintain anxiety and depression. Now, given that we really need more accessible interventions for anxiety and depression, then targeting RNT seems to make sense. But what we need to know is whether the mechanisms that maintain RNT are transdiagnostic themselves. So that's the first question that we wanted to address. Okay, so are different forms of repetitive negative thinking associated with transdiagnostic interpretation bias? And this was led by Charlotte Krahe. So we know that worry is central to generalized anxiety disorder. So generalized anxiety disorder seemed a really good population to be trying to look when worry is the dominant form of RNT. And rumination is very often occurring and problematic in depression. So again, that it makes sense to have depression as our clinical problem that we're focusing on, to really understand whether focusing on worry in GAD will impact rumination and vice versa. So, but in this first study, we were just trying to understand whether interpretation bias is evident across these different populations of the control group. So we have a task which involves generating interpretations. So you're given ambiguous scenarios. In this case, it's you're being in a car park and you hear a noise, and it's left ambiguous. And then later you make a rating of the scenario. And from this, we can deduce whether people have a tendency to make negative interpretations of ambiguous information or positive interpretations. So what we found was across people who were from the general population and those who were currently suffering from generalized anxiety disorder or depression, that across the whole population, there's a strong relationship between lower levels of worry and rumination and higher levels of negative interpretation. So, sorry, the other way around. People who have worry and rumination are people tend to have more negative interpretations. Sorry, this. It's just moving the slides forwards is really hard for some reason. And that's gone too far. And then similarly, if we look at the groups themselves, there's a negative interpretation bias in people with anxiety, and sort of no bias in those with depression, but the people without these problems have a tendency to make more positive interpretations. So what we then wanted to do is really understand the causal role of this. So using a technique that someone in the conference have helped develop as well, like Tim McLeish, we use cognitive bias modification of interpretations to really test whether there's a causal role for these interpretations in driving repetitive thinking. At this point, no studies of multiple sessions of interpretation training had really looked at worry and rumination, and we wanted to sort of engage people with lived experience of worry and rumination in helping us really tailor the material. So people who were going to be who had generalized anxiety disorder, so a dominance of worry, were going to be given worry materials, and people with depression were going to be given rumination materials. And we're going to see whether changing these, the interpretations related to those different forms of repetitive thinking had an impact on the other forms of thinking, as well as on anxiety and depression. So we recruited people who had either generalized anxiety disorder or depression, and then they completed sessions of the training, the interpretation training, using our platform. They attended the university before and after the home-based training, and then there was a 1-month follow-up. And as I say, people were trained in their dominant form of RNT, so worry if you had GAD rumination, you had depression-related materials. You had 10 sessions of 25 minutes, and you had to listen to ambiguous scenarios. And in the active group, the ambiguity was resolved in a positive way. but in the control group, it remained ambiguous. So it's a very similar task, but we weren't changing interpretations. And what we found was that this training led to more positive interpretations, so that's good. But also later on, a month later, you also had reductions in worry, rumination, and depression across all participants. And those who'd received the worrying materials actually had a reduction in anxiety as well, but not those who had received depression materials, rumination materials. So we can see that repetitive negative thinking increases positive interpretations, and it then has a impact on worry and rumination to a similar degree, irrespective of whether you're targeting worry-related interpretations or rumination-related interpretations. And this has a longer-term effect. So really supporting a transdiagnostic view of RNT and then the mechanisms that maintain it. So then we wanted to really improve the intervention by thinking about how we can enhance impact. And so everyone was told in the original study to imagine themselves in that situation, but what we did is we really increased the practice and training of engaging in positive interpretations by self-generation and imagery. And we also were then recruiting people who had worry and or rumination, but they didn't have to have a diagnosis. But we did use that we ensured that they were above a clinical cutoff on dimensional measures. And you were basically allocated to your dominant form of repetitive negative thinking. So in the self-generation, sometimes you were given a positive ending, and then sometimes you heard a scenario you'd heard before, but it's left ambiguous and you made your own ending, or you were given a completely new scenario and you generated your own ending. And then for all of these, it is in the active condition, you then had about 7 seconds to imagine yourself in that situation as clearly as possible. And we used questions after these trials to try and really enhance performance. So as I said, people were assigned to the dominant form of RNT, and there was a standard condition of cognitive bias modification from the previous study, or this enhanced version, or a control condition. And then collapsing across the interpretation training interventions, we found that, again, we could change interpretations, and that a month afterwards, impacts were sustained on the symptoms of anxiety, depression, repetitive negative thinking, worry, which was weekly worry, not trait worry, and repetitive negative thought intrusions. But the difference between the new enhanced version and the standard version was that we could actually have greater impact on positive interpretations and a greater reduction in negative thought intrusions. And we also managed to impact on rumination. So this bigger package seems to be better at targeting transdiagnostic repetitive negative thinking. So in a final study I want to tell you about, we had people where we knew that worry was a central problem, but they would also, some of them also had comorbid depression, so rumination would be a problem as well. But everybody was given the worry materials, and we assessed the impact of on worry and rumination by targeting just the worry interpretations, as well as anxiety and depression. This was a fully online study, so they didn't come to the university at all and were recruited from across the UK. And we had a 3-month follow-up as well. So in terms of change in interpretation, with session 1 is prior to the intervention, and session 2 afterwards. As you can see, we were able to change interpretations. This is the worry score on the Penn State Worry Questionnaire, and up to you can see that in the blue line is the active condition. The control had been doing the other type of listening to scenarios that don't change your interpretations, and there was greater reduction in the active condition. Similarly for rumination, for anxiety and depression. So it seems that a fully online training with this enhanced imagery and self-generation is feasible to deliver, which not all CBM programs actually seem to work when done at home, and that they promote positive interpretations. And that 3 months follow-up, which is the longest we've tried to test so far, we find really clear findings of reductions in repetitive negative thinking and mood, and aversive mood. And what we found was that this interpretation bias change mediated the effects. And interestingly, importantly, comorbid depression didn't impact on the findings. So despite being focused on worry-related interpretations, there was a people had showed effects that were exactly the same, whether they had depression or not. There was really good compliance with the people completing the training over the 3 weeks, and there was very positive feedback on exit interview. So now we are combining LENS with CBT in the Maudsley, where I work, to see whether that can be helpful in enhancing kind of CBT. And we're looking at, one of my PhD students is looking at identifying predictors of outcome for CBM, cognitive bias modification for interpretations. But we've also adapted the platform and the materials to be more pertinent to people who have difficulties with worry and anxiety with co-occurring long-term physical health conditions. So anxiety and worry in Parkinson's disease and multiple sclerosis, distress around fatigue in a range of different physical long-term conditions, and whether we can promote, rather than just looking at worry and anxiety, actually promoting resilience in cancer survivors. And these are being examined in feasibility studies at the moment. And soon we'll be commencing an efficacy trial to prevent perinatal anxiety using an adaptive form of the training I talked about today, where we really will work with individuals who've got lived experience of being pregnant or a new mother and very anxious, to really make sure we're going to be targeting pertinent interpretations to try and reduce R&T in the hope that that will prevent escalating anxiety during pregnancy. And actually we're recruiting for a trial coordinator. If anyone is interested, please get in touch. Okay, so thanks for everyone who took part in the research. Really massive thanks to the panel of people who have lived experience of anxiety and depression who guided our research, and my co-researchers and funders.
Thank you, Colette.
I had to do it quick so we catch up on time.
Oh, you're an expert, so you know how to do that, don't you?